Okay, thank you everyone. So my name is the DW Park from Asan Medical Center. We're gonna start the afternoon live case session. This is a real live case demonstration. I'm gonna introduce the co-moderator, Dr. Takeshi Akasaka, and he's a worldwide famous imaging specialist, imaging and physiology specialized interventional cardiologist. I'm going to introduce the whole panel and Dr. Shitechi Chahan from India, Dr. Viray Kesan Charan in Thailand, Dr. Vincent Kok in Hong Kong, Dr. Masashi Okuchu in Japan, and Dr. Hanbi Park from Korea, and Dr. Sodik Rifi in Indonesia, Dr. Ying from Taiwan. Okay, Dr. Takeshi Akasaka, and can you introduce and start first case, live case demonstration?
Okay, thank you, Dr. Park. I'm Takashi Akasaka, and thank you very much for a kind invitation and welcome all participants. So today we will have two cases, complex cases from Asan Medical Center. First one should be bifurcation, and second one should be instant restenosis. So I would like to introduce Dr. An. He will introduce the bifurcation cases. Dr. An?
Okay.
Hello,
yes, I can
hello.
hear you. Good afternoon,
nice
Dr. Akasaka. So I'd like to introduce my case, third case. Dr. Gosadi will introduce briefly the patient case history.
Okay, thank you very much. I'm Dr. Gosadi from Saudi Arabia. Our patient today is 72-year-old male patient was referred for abnormal result of coronary CT imaging. He has been treated with hyperlipidemia and hypertension and diabetes mellitus. Coronary angio showed subtotal occlusion at proximal circ and diffuse severe stenosis at LAD. Next. As you see, he has a risk factor diabetes, hypertension, hyperlipidemia. Next. ECG is normal, sinus rhythm. Next. Chest X-ray also normal. Next. Echocardiography showed normal ejection fraction without wall motion abnormality. Cardiac catheterization showed the left coronary angio showed a near subtotal total occlusion of the proximal circ and diffuse severe stenosis at proximal and distal LAD and diagonal branch. Collateral flow from the PL branch to distal circ grade 3 was observed. The right coronary angiograph showed tubular moderate stenosis at the proximal segment. Next. As you see, this is the RCA. As you see, there's a proximal segment moderate stenosis. Next. And this is a caudal view of the circ, which is showed almost subtotal occlusion of the circ. And also there is a diffuse disease proximal and mid LAD with diagonal. Next. Same finding showed here, distal and diffuse disease of LAD. Next. Okay.
So thank you, Dr. Gosadi. So this patient is stable angina patient. So the coronary angiogram show very tight stenosis circumflex. Can you see the stenosis?
Yes.
Okay, we can see.
Yeah, but the anatomy is very ambiguous. I'm not sure where is the true opening of tight stenosis. I cannot see. Next, please. AP cranial view, the LAD diffuse digit FFR is negative, so today we are focused on the circumflex. Even though in this view there is a haziness in the tight stenosis of circumflex, but it looks very calcified lesion, but not easy to see the stenosis. Next, please. This view as well. Next. Yeah, very tortuous. Next. Yeah, I tried to insert wire to the circumflex, but I think it takes time So please see the second case while I am trying to insert the wire to the circumflex.
Okay.
Okay, I'll call your data. Thank you very
Yeah.
much. Okay.
Okay.
So,
Dilation.
Dr. Khan, can you
Yes.
hear me?
Oh, yes, I can hear you.
Okay, please try to introduce your team and case,
Yes.
and then, yeah.
Nice to meet you in virtual, and welcome to Complex PCI 2021. I'm Dr. Do Young-gang, and this is my senior fellow, Yeon-jung Lee. She will introduce our very interesting ISR case. Can you please?
Yes, I introduce this live case. He is 60 years old male and he received the PCI 7 years ago for stable angina treatment. He recently had a chest discomfort and his myocardial image showed medium-sized defect and mid-basal anterolateral wall. His cardiovascular history, when we showed his cardiovascular history, he had no myocardial impact or CABG, but since 2011, he had a PCI at his coronary disease, and 2 years ago, he had a ISR at left main to proximal LAD, so he did receive the drug-eluting ballooning. Next. He had a diabetic and hyperlipidemia, and he has a stable angina class 2. Next. His EKG shows normal sinus rhythm, and he didn't have a ST elevation. So next. And his cardiac chest X-ray shows the cardiac enlargement. Next. He did several non-invasive studies. His echocardiography shows apical imperial lateral apikinesia with borderline LV dysfunction. He also did Saulian spec test, and he showed partial reversibility in mid-size and moderate at mid-basal anterolateral. We did the coronary angiography, and left coronary angiography shows significant stenosis at left proximal LADOS and patent left main to proximal circumstance. And right coronary angiography shows patent RC stent. This is his angiography. And we did the FFR test. FFR test confirmed 0.6, so we decided to do the intervention. This is his angiography too, and the spinal view shows LADO significant stenosis.
Yes. In summary, the relatively young 60-year-old patient already received multiple PCI. First, 10 years ago, he received stenting at the prox-LAD and the prox-LAD and left main to circumflex crossover. And then 2 years ago, he received additional prox-LAD DB and circumflex Pullback for ISR. So this patient now shows the proximal LAD recurrent ISR even after one-time DEB. And circumflex ostium looks relatively preserved. So the patient's stable angina and recurred ISR on the prox LAD with the closed stent to the left main to prox LAD and another stent on the LAD. The crossed over stent from the main to circumflex and another stent at the prox LAD. So anatomically relatively very complex, and this is the recurred ISR with the complex left main previous stent anatomy.
So Dr. Gang, there is some complex explanation, and this patient, the distal left main looks like a very complex. This patient underwent some complex two-stent technique for distal left main or any another technique? I don't fully understand.
10 years ago, he received left main to circumflex crossover, and then prox LAD was separately stented. But we don't know about the exact technique because it was 10 years ago and in another hospital. And 2 years before, we treated this patient for the prox LAD ISR. At that time, we performed the 3.0 NC at circumflex,
3.5 at the prox LAD with the dB, and then prox LAD record.
Is LAD ostium was covered by stent or not?
It was covered in the previous image. So we don't know just about the technique itself, so we need complex imaging for the evaluation of the whole anatomy of this patient. I think that panels would be agree with that. So we checked the FFR, and prox LAD FFR was 0.6. And can you please show the angio? This is today's angio, shows similar finding, and we checked OCT for evaluation of this complex anatomy. Can you please show the OCT image? Yeah. This is pullback from the circumflex. Yeah. Let's share the image. Yeah. Here is the distal circumflex. You can see some narrowing and 2 layers of the stent. And here we came into the left main. Can you please show with a more slow pullback from the prox circumflex? Yes.
Oh,
Here,
Okay, good.
let's move cut by cut. Here is the circumflex. 조금만 천천히 갈까요? Back, back, back. Okay, yeah. Cut by cut, yeah. You can see the lumen area is about 4.4, automatically calculated, and there are 2 layers of the stent of the previous stenting. You can clearly see the 2 layers of the stent. And at the 5 o'clock, there are many layers of the previous stent. And here is the ostium to the left main. And we came into left main, and at the 12 o'clock, you can see some malopposition of the stent with some lumens. Even after 3.0 and 3.5 and kissing with 2 balloons at previous procedure, still there was some malopposition at the left main. And let's
So by OCT, LAD ostium was a bare area. It's not covered by stent, right?
let's see again about the left LAD pullback. LAD. This is circumflex pullback, and at the just distal left main bifurcation, there was still malopposition. And this is pullback from the mid LAD. Yes, pullback, please. Yeah. Yeah, play. This is the previous stent at the prox LAD. You can see. And there's some bare portion in very short
bare
length.
portion.
And here is the prox LAD, and still you can find the stent. Can you please show the from prox LAD and cut by cut? Yes. It's prox LAD, and the disease begins. The stent, you can see that very complex, but here, stop. Here is the ostium of the LAD, and you can see the stent. Next. And here's the ostium of the LAD. And here is the distal left main with some malopposition. Next. Move on. And 2 layers of the stent here. And the left main shaft is some calcified, but stent is well opposed. So in this, summarizing these 2 pullbacks, circumflex ostium is diseased, but the lumen is relatively preserved. And prox LAD, there is large plaque burden, and the stent is covering the ostium of the LAD, but distal left main has some malopposition with the lumen not covered by the stent. Can you please comment more on this complex OCT image?
Okay,
Yeah.
so at this moment, we will have a discussion time.
Yeah.
And Dr. Akasaka, how do you think? Is the FFR, was the LAD FFR 0.6?
It was, yeah.
But lumen area LAD ostium, not much severe. Seems like a 4.0. Did you measure the lumen area at the LAD ostium?
The narrowest portion was 3.6. Can you please show?
3.6.
Yeah.
Okay, here is automatic measure the minimal lumen stent area 3.6.
Here.
So yes, and angiographically looks like a slightly ambiguous region. There is some mismatch and imaging and FFR and something like that? How do you treat this, Dr. Akasaka and any panel? Yes.
Right. Anyway, we have to treat the left main incomplete position using a bigger balloon, higher pressure, right?
Yeah.
And then actually the FFR of the LED is significantly low. Therefore, we have to, yes, treat the proximal LED. But the tissue should be, I think, the fibrous mainly, right? Therefore, anyway, we try to use the scoring balloon or a cutting balloon or any kind of balloon within the high pressure. And after check the result of ballooning, we will decide we need another stent or not, right? But patient have a drug-coated balloon treatment in LAD previously, or
Yes.
I think, right?
Yes, that's right.
Right. So, but stent in stent is not an ideal. If we can avoid, we try to treat without stenting if possible. But in this case, I'm not sure. It might be difficult. But anyway, we have to check the response to the ballooning, right? And then we will decide. Yeah.
Okay. Any comment from panel? And how do you treat this region? The
Yes.
FFR was decreased angiographically and intermediate, but lumen is 3.5. How do you treat? Any comment?
I'm Dr.
Okay.
Yin.
Okay,
I think
okay,
we should treat it, of no doubt. And I also agree with Dr. Akasaka. We will pre-dilate the lesion, usually with a cutting balloon, to see the outcome and aggressive post-dilatation with non-compliant balloon followed by DCB maybe. And I also wonder, in old days, we will try some debugging before the further treatment. Yeah.
As I agree to that Akasaka and that In's opinion. And as before looking the image, I planned some new stenting because this was a DB failure. But when I checked the OCT, I could find that there is still mechanical problems that we can correct. So I decided to use the much bigger balloon to open the left main bifurcation. Next. And use the 3.5 for the circumflex next, and 4.0 next. 4.0 for the left main. This is the 4.0 NC at the left main.
4.0.
Yeah, next. Up to 28 ATM. Next. Yeah. And this is circumflex 3.5 NC up to 26 ATM because we checked the vessel size of the circumflex and left main, and it was much bigger than balloon size. So I selected more bigger balloon than previous procedure. Next. And did a kissing, and now we are here. And let's check the angio after this aggressive NC ballooning.
It's LAD 4.0, circuit 3.5.
Yes.
Okay.
And shall we check the OCT again for the prox LAD to left main?
Okay, I think lumen was much larger,
Yeah.
not remarkably, and slightly larger. So I don't know what happening. The OCT post ballooning OCT would be helpful to delineate about some change.
Yes, in this situation, angiography is sometimes we cannot believe it. So intervascular imaging gives us the correct information. Okay. Ready?
Yep.
Angio. Yes. Because of the left main disease, I used the guiding catheter with side hole, so imaging quality can be a little bit lower. So please understand it. And here you can see the lumen became bigger. Okay. 네, 다시 한번 볼게요. Okay. Here is the prox LAD. You can see some balloon related dissection. And here Still, the vessel is some eccentric, but lumen became more than 7 now.
More than 7.
Yeah.
The
And here
people
is the
ballooning
POC.
3.5.
Yes.
3.5.
Yeah, left
Now
main to LAD
is
4.0 it was.
now is 5.8.
Yes. More please. Yeah. Here's the left main. Okay. In OCT and angio, please. And angio and OCT, the lumen looks bigger than before. 그 전은 거요. But still, there's some restriction of the circumflex left LAD ostium. Then, what's the panel's opinion about the treating after this step? More high pressure balloon or cutting
So at
DB or DS?
until now, and he did perform the NC balloon high pressure
Yes.
balloon dilation 4.0 LAD part and the 3.5 suck part, and then the 2 times kissing balloon dilation, and geographically looks better than before, and the lumen, the OCT showing the lumen area is much bigger, is 5.7. So at this moment, what would your opinion from the panel, or is what would be next step? It's just a leave it alone, or DB, or additional another stand? How do you think is panel?
I will further dilate with a cutting balloon.
Cutting balloon.
Because sometimes the fibrotic tissue is really hard to break. So I think a cutting balloon can make longitudinal further dissection, and after that I will do more aggressive NC balloon dilatation before DCP.
Dr. Kwok? Okay.
I think the mechanism of the restricted expansion is two-sided. Of course, you've got a lot of tissue overgrowth, the new intimal hyperplasia, which I agree with Dr. Yin that I would probably use the cutting balloon to improve the expansion within the stent. And I'm not sure whether the restriction is partly related to calcium behind the stent. If you've got calcium behind the stent, nowadays we use a shockwave balloon to crack the calcium behind the stent. I've got several cases of ISR which came back, 10 years later, and we used a shockwave with pretty good expansion, especially if the stent was placed years ago. Then I think it can help to break some of the new atherosclerosis or calcium behind or between the two stents.
Yeah, we could see the calcium just around the bifurcation, I think. Yes, very thick calcium, eccentric calcium. Therefore, the shockwave is one of the way. But I do not know that is really effective in the circular calcium. We can make a plug, but in this case, I do not know the effect of the shockwave.
I have one comment.
So I think most of the panel is hesitate to put the additional another stand, and some recommended the cutting balloon will make some change. And Dr. Kang, how do you think is cutting balloon?
Yes, I also agree with the panel's opinion, because there is also 2 layers already at the left main bifurcation. So to avoid the additional stenting is what I want, and to avoid that, I think I have to do everything to restore the lumen, and cutting balloon would be a good option. And also, lithotripsy would be a very good option for this kind of patient, but unfortunately, it is not available still yet in Korea. So I will use the 3.5 cutting at the prox LAD to open the ostium in the long-standing neointimal hyperplasia.
Yeah. So, and the practical point, I think at this time, is cutting balloon we can apply, and then high pressure balloon dilation, and make sure it's a much larger, big area, and then ISR was recalled. We can refer this patient to mid-cap or bypass surgery. That is also good option. Yeah.
This is 3.5 cutting, and I break it up to 18 ATM. 18.
Yes.
18입니다.
So usually label recommendation is maximum
12,
ATM is
maybe.
12, but it's on the basis of the prior experience,
Yeah.
20 ATM,
18.
the is
Yeah,
It does not break
usually
yeah.
okay. Yeah, this is
Yeah.
18,
Deflation.
3.5.
And
Okay,
then pull it out.
Would you do DEB
And
again with
rotate
another drop?
again. Rotate after rotating. I go in again. That's 18 again.
18입니다.
18,
Yeah.
3.5 cutting
Yeah.
balloon.
Deflation.
This is conventional cutting balloon from Boston Scientific,
Yes,
right?
that's right. Flex tom. 18.
Blackstone. Yeah. 18.
18입니다.
There are some that we want to some change of the
Yeah.
prior calcified neointimal hyperplasia.
Yeah. It looks
Okay.
that still there is some indentation, but I will check again. Deflation.
Okay.
Dr. Kwok, do you have any comments?
Yeah, would you consider DEB again with another medication? I think
18.
the previous DEB was paclitaxel, right?
18.
Yeah, right.
Would you consider other
4.0
DEB
주세요.
with sirolimus?
So, okay, any the experience from the panel, and in Korea we just use available paclitaxel coated balloon from the Boston or Circumflex, B Brown, and different three companies developed the DEB, but it's all the paclitaxel loading balloon, and so we don't have experience with sirolimus or any other different type drug coated balloon. Any experience from Dr. Ng or in the
Yes, we do have a magic touch, I think. Yeah, it's almost similar performance.
세건 하실래요?
But regarding the balloon size, why not use 4.0 cutting? You have
Is it-
already done a 4.0 balloon dilatation.
So I know that just the 3.5 would be maximum diameter is available, right? Is it Doyun?
Yes,
How do
now
you think?
3.5 cutting is the maximally available diameter. So I use the biggest one and apply 20 ATM. And I will further dilate with the 4.0 NC, a very strong one, to maximize the opening of the LAD. This is 4.0 again. And let's dilate again. 20.
This is a
20입니다.
24.
yeah,
24.
4.0 NC
Yes.
balloon again. Okay, I think much
Geographically, it
improved.
looks better than before.
Yeah, better than before. It's fully expanded, and then you're gonna do
26.
final kissing balloon
26,
dilation,
28.
right?
Deflation. Yeah.
Okay, good, much better.
Once again. 24.
24입니다.
Okay. Deflation.
Okay, so we can see and the lumen diameter much improved.
Okay.
Okay, you applied the 4.0 NC balloon.
Yes, 4.0.
And then what is next step? You're gonna do the kissing balloon dilation, or
Shall we check OCT again for the panels and the audiences?
Okay, got it.
Yeah. Let's see the
okay.
change after cutting balloon. And that would be very educational for this case.
Okay, great.
If it is fully dilated, and then we can apply the kissing and then DB kissing for this patient. And the
So,
parents, do you have any experience with the DB kissing for the bifurcation ISR? How do you finish the ISR, bifurcation ISR, when using DB?
So and we also have a DB kissing balloon, and this is the re-showing the OCT imaging after cutting balloon dilation. So have you the panel any experience for intravascular resorption for such like a calcified ISR lesion? Dr. Kwok? Okay.
Yeah, we did a number of cases. I think it helps a lot, especially for old stents. And as you know, we've got a lot of new atherosclerosis in our oldly implanted stents, and I found that it's very useful in cracking the calcium, and it helps the expansion a lot.
있어요. 오케이.
한번 이미지를 한번 더 볼까?
이미지,
조금
이미지
흐린 것
again.
같다, 그죠? Image again. It's more clear image.
Yeah,
Okay.
image quality is not so good, so I'll
Yes.
try again.
Stand by. And this guidance has the with side door, right?
Yes, we use the with side hole because the left main stenosis. I did not want to use the guiding with outside hole. This is. Let's see again. The left main.
Okay.
Yeah. Okay.
조금 더. Okay.
Yeah. Okay. See again. Yeah. Ready? And you.
Much better, much
The
better.
imaging is much
Yeah.
better with a full impaction of the guiding cutter.
Oh.
Now the lumen became much bigger than before.
Yeah, yeah.
The cutting
There was
balloon and
There was a big change.
again, yeah, large change. Cutting balloon worked, and then. Can you please show again the minimal lumen area at prox LAD and LAD ostium became much larger, up to 9.
Yeah. In the before any ballooning is at nearly 3.0, and then initial kissing balloon 5.6. Now it's 8.6. Much improved. Yeah, it's good.
Then I will now apply the 4.0 and 3.5 NC for the kissing. Very high pressure again, and apply kissing. After then, we'll apply the DB kissing for this patient.
Okay.
Yeah.
Okay, good, excellent. So, and the IVL intravascular resorption, all data disrupted study showing the very nice efficacy and safety, and we didn't have experience yet and not yet available in Korea. And I think in the future, the intravascular resorption would be one of the good options, such like a calcified ISL region.
Yeah.
This is 3.5.
And how about the imaging for these ISR cases? Does panel prefer imaging or angio guided or OCT versus IVUS? Which do you prefer? The expert panels.
Professor Akasaka, in your catheter, which modality is mainly used?
In our catheter, nearly 80 to 90% now the OCT guide.
OCT.
Yeah.
Okay.
Only a
good.
few do the IVUS, just for CTO, or just orifice. But recently, just orifice. If you use some extension catheter, we can see the main orifice through the extension catheter, right? Yeah.
Okay, good.
This is 3.5 NC. Yeah.
Okay,
We are
good.
performing the randomized control trial comparing OCT versus IVUS in all comer patients, including left main and complex disease deflation. And in my personal opinion, I prefer OCT, especially for the ISL region, because we can see and clearly see the images and discriminate the instant calcium and sense trot easily with OCT, and that is very helpful for the procedure. 24.
So, and we plan the 2,000 patient Optimus trial is a all-comer real-world pragmatic trial comparing IVUS versus OCT guided PCI, and the minimal exclusion criteria was applied the patient with the renal insufficiency, and we nearly enrolled more than 1,900 patients. The end of this year, we expect the final enrollment, and 1.5 years later, we will shows the final result of Optimus trial.
Great study. Yeah.
Yes. This is a final kissing.
Final kissing with the 4 and 3.5 by 12 ATM.
Yeah, good. You know, we can see where, and after cutting balloon dilation is much dilated where LAD ostium part, as well as distal lemma part.
Yes, it really worked. And then I will apply the DB for 4.0 and 3.5. 적었어요. 랭스 20에 20, 20. 네. 예, 적어주면 돼요, 에이전트.
에이전트 4.0인식,
네.
3.5인식.
We also apply the 4.0 and 3.5
and the DB.
Yeah, we
is
only have the
8.
paclitaxel the balloon, so I will use the 4.0 and 3.5 both with the kissing. And in this kind of case, I usually prefer long duration inflation for ISR DB. But in left main, it is not so easy to keep the ballooning for more than 1 minute or more. So I will apply the short time, 20 or 30 seconds, or 2 or 3 times for patient safety.
Okay. So, and the DB Rabelling recommended at least 35 seconds, but for like distal and main region is the occlusion of more than 30 seconds sometimes the hazard.
Yeah.
Okay, good.
Usually we how long will balloon be inflated? Will up to the ECG change or the symptom or hemodynamic change? Because this patient has a very big right cord, and maybe he can tolerate longer.
Yeah, let's see what happens. And if the patient is tolerable, I can inflate longer time. But we must closely monitor the vital sign and EKG as they change. Okay, close. Okay, this is 4.0 paclitaxel electing balloon at LAD.
Good.
And 3.5 at circumflex.
This is the DB.
Yeah, nominal.
Okay, great.
Yeah, 6.6.
하나, 둘, 셋.
You are
Six.
simultaneously
Yeah.
apply the DB. Okay. Wow.
Yes, it's very well expanded, and blood pressure is stable without ST change.
You should be careful.
Yeah,
we can wait more than 30 seconds at this moment. Oh, I feel my chest pain.
Blood pressure is a little bit down, deflation.
하나,
Okay.
We applied 30 seconds, and blood pressure is down. ST
Yeah.
depression you can see, and I will wait here.
Okay.
The pressure recovery.
13 seconds.
13
Okay.
seconds.
Wow.
30 seconds I applied.
30.
30.
30.
Yeah, 30.
Oh, you are very brave.
And ST change is fully recovered, and pressure is up now. And let's do again, because the drug is delivered by the diffusion, and long time contact is important for drug delivery. Again, pressure is okay. Yeah, 6.6.
하나, 둘, 셋. 6, 6.
Okay. Circum 7.
Circum 7.
Okay. Timer 10 seconds. And 20 seconds. Some ST depression and blood pressure is down. Deflation.
하나, 둘, 셋.
Yes.
Oh.
Totally,
Okay.
I
Wow.
apply the 30 seconds for 2 times, and totally 1 minute. And I
Okay,
think
good.
it would be enough for the
Enough.
Yeah.
Sufficient.
But the patient is very tolerable. As Dr. Yin said, the patient has the large size of the RCA, and long-term ischemia, chronic ischemia, so the patient will be tolerable. And then I will check the angio and final IVUS for the patient.
Final OCT. Okay.
Okay.
Good. Excellent.
Okay. There's some problem removing the balloon. Okay. Now it's okay. Balloon is out. And 자, 제거해. 당겨가. Let's check the angio. Okay. Angio,
Yeah.
please. Okay. Oh,
Good.
Roman looks
good.
much better
Excellent.
than before.
Okay,
Yeah,
much better.
Check the final OCT, what happens at the left main and prox LAD.
Okay, good.
얼마나 남았나요? 두번 맞출 수 있겠네.
Okay. 잘
circum입니다.
맞춰볼게요. This is circumflex.
Mhm.
Okay, 놓고. Okay, let's review the circumflex OCT. I just see the prox circumflex. 네.
됐습니다.
그죠? Okay,
Good, good, good.
let's see the circumflex ostium. The proximal, the stent is more
Good.
well dilated
Oh, wow,
compared
excellent.
with before. Yeah.
Yeah, we can see well the carina and the POC area.
Yes,
It's
and
good.
marrow position nearly disappeared
Great,
at the left
great.
main. Yeah. Then I will check the prox LAD to left main. Okay.
Okay. And then you will check it up the final, the LAD to left main,
Yes.
and then finish.
Here, let's check.
네.
그죠?
Good, good, good.
The
Can you?
left main bifurcation is well visualized. Let's check.
Okay, here.
Here,
Okay.
the proximal stem and the prox LAD.
Okay.
Yeah, there was some.
Yeah. But however,
Not
the
clear.
LED ostium was well
다시 보여주세요.
dilated well.
Yeah.
Okay.
다시 보여주세요. Okay. Now I can understand, but there is some the image next. Let's check the angio.
Yep.
Yeah. Angio. Okay.
Good, good.
I'll see the caudal image. 다시 OCT 뜨면 보여주세요. 오케이. 그죠?
네.
Okay.
Good.
Roman is
So,
much better when list
yeah,
forward.
yeah.
Yeah.
So I think much better, and we applied the high pressure NC balloon and the cutting balloon 3.5, and then additional NC balloon and kissing, and the final DB applied, and the final result was great and excellent. So any comment from the panel for the another option or another suggestion? Okay, Dr. Bob? Yeah.
Yeah. Were you using a cyto guiding catheter?
Yes. That's why the OCT image is not so good. I'm so sorry, but because the patient has the left main disease, and I did not want to obstruct the left main with the guiding catheter for the patient safety. So that's why I used the guiding catheter with side door. In usual PCI, not left main, just LAD or circumflex, I use the guiding catheter with the outside hole for the OCT image, good OCT evaluation. For left main, I usually use the guiding catheter with the side door, and sometimes if image quality is poor, using the guide extension catheter would be helpful for the minimizing the side hole, the leakage, and to visualize the ostium of the left main. Because of guide liner and telescope, the OCT can visualize outside the guide extension catheter. So in that case, it is very helpful. But still for the safety, I used it.
Great,
But would
great.
it affect the initial FFR assessment?
Yeah.
If you are using a cycle catheter?
At initial FFR, I also used the sidal catheter, but I disengaged the catheter outside the left main ostium and then checking the FFR, so I believe that the value would be accurate.
Okay. So I think the result was excellent. So, and unfortunately, in the room number 1, and the Professor An, the guide wire passage is not easy. He spent forcefully 45 minutes, but does not pass well. So yeah, it's not easy case. So at this moment, and I would like hear the lecture, and then we will have a final discussion time. Okay, Professor, Dr. Akasaka, can you introduce the featured lecture in this session?
Okay, thank you. The feature lecture will be, presented by Dr. Do Khan, right? The title is Update Imaging Guided ISR PCI 2021. Dr. Khan can.
Good afternoon, ladies and gentlemen. I'm Dr. Do Young from Asan Medical Center. Today, I will talk about the updated imaging-guided ISR PCI. I have nothing to disclose. The instant restenosis means the reduction in lumen diameter of the PCI, and it consists of about 10% of PCI in US and 5% of PCI in Korea in IRIS registries. There are two major causes of instant restenosis. One is mechanical factors, and another is tissue regrowth. Stent under expansion is the most common cause of the mechanical problem, with the undersized stent, recoil, or peristent heavy calcification that avoid the expansion of the stent. Also, stent fracture or gap can cause ISR. And neointimal hyperplasia is the most common cause of the ISR. And in long-standing stents, neoatherosclerosis with the neovascularization or calcification inside the stent can happen. And intravascular imaging for ISR provides information of underlying mechanisms of the stent failure. Let's review with a case. 75-year-old male patient was admitted for aggravated angina for 1 month. He had a history of diabetes, hypertension, and implanted 3x24DS at proximal LAD 13 years ago. This is the CAG and the PCI performed 13 years ago, and then we have the 13 years ago IVUS, the after stenting. The distal stent was well approached and well expanded with the 3.0, and proximally, stent size is a little bit smaller when compared with the vessel size. And at the very proximal edge, there was small degree of the malopposition here. Yeah. And the EKG and chest X-ray echo was normal, and we checked the coronary angiography, and there was PDA stenosis here. And there was intermittent disease in the OM and diffuse ISR in the LAD. We checked the FFR for LAD, 0.74, significantly low. We decided to perform PCI at LAD ISR. This is baseline OCT and IVUS image. We performed 2 simultaneous imaging to directly compare 2 imaging modality. This is OCT. You can see the imaging speed is very fast. And here, distal edge is clear and branch came in. And you can see the calcification inside the stent that means neoatherosclerosis. And remains here, you can see severe calcification and proximal edge, the edge is clear. And also in IVUS, you can see the same finding. Here, distal edge is clear, and there is a severe calcification and plaque inside the stent. But discrimination between calcium and stent is a little bit difficult compared with the OCT. Here is the most severe, and proximal edge is okay. And so the ISR with the neoatherosclerosis with the minimal lumen area about 1.7 or 1.9. And also at the proximal part, there was under expansion with the stent size 2.9 when the vessel size was 3.5 or more. We performed the cutting balloon 3.0 and then rotate and again cutting balloon was done. After cutting balloon, the lumen was restored and we checked the OCT and IVUS again. You can see the cracks of the ISR by the cutting balloon, even in the calcified neoatherosclerosis. Also in IVUS, the same finding can be seen. And so lumen was well restored. And for the further dilation, I applied the NC 3.5 balloon up to very high pressure. And then how to treat? There are two options, the drug-coated balloon or DES. Which should be better? There are many meta-analyses comparing two modalities. And recently, a large-sized patient-level pooled analysis of the 10 RCTs was published, and it showed the target lesion revascularization was lower in DS group, the red line. And the hard endpoint, composite of all-cause death, MI, or target lesion thrombosis was similar in both DCB and DES. So concurrent data shows that slightly better angiographic outcomes in DS and more TLR in DCB and comparable hard outcome in DCB and DS. So the patient is the first time the ISR, and I did not want to add one more metal layer, so I applied drug-coated balloon for this patient for 1 minute. And this is the final OCT and IVUS after DCB. And you can see in both sides, and the lumen was, it is the edge here, is clean without edge problem, dissection or hematoma. And we move to proximal, the lumen is well restored. And you can see that the calcified neoatherosclerosis also well dilated with the cutting and NC balloon. At the very proximal edge, you can see very minor dissection, but the lumen is well reserved. So we finish the procedure here. Also in IVUS, you can see the lumen was well restored. And at the very proximal edge, you can see the calcification and no edge problems can be seen. So MLA before and after PCI, it restored to from 1.7 to 8.9. And stent diameter was 2.9 before the procedure and was well dilated up to 4.0. So in this case with the neoatherosclerosis and under expansion, the patients were treated with the cutting NC and drug-coated balloon. As you can see in this case, intravascular imaging in ISR PCI can help to identify the mechanism of the stenosis and select the optimal treatment modality. For example, high pressure balloon for under expansion, DS for fracture, gap, or edge problems, DB or DES for neointimal hyperplasia, or atherectomy or lithotripsy for undilatable ISR. Also, we can optimize the ISR PCI result and can give instant feedback to the operator. And OCT versus IVUS, which should be better? In ISR imaging, OCT can visualize in more detail, like stent strut coverage or discrimination between stent and calcium, dissection edge problem, and also better for the BVS related problems. However, it needs contrast filling, and sometimes it has difficulty in austere visualization. So OCT and IVUS has advantages and disadvantages. and ongoing Octaves trial with the all-comer PCI, including main bifurcation, also ISR, comparing OCT versus IVUS guided PCI, will be able to give you some more information about the role of OCT versus IVUS in ISR PCI. Now, the guideline recommends DS and DB both in the 1A recommendation, and IVUS or OCT as the 2A recommendation to detect stent-related mechanical problems. So this is my treatment strategy. And when I meet the ISR patient, check the intravascular imaging. And if there is underexpansion, apply high pressure balloon. Tissue regrowth, currying, scoring, NC balloon, use anything to make the lumen bigger. And assess the angiography and imaging. If the lumen is fully dilated without complications, apply DCB. If there is some complications like large dissection or edge problem, apply DES. And if the ISR is undilatable, apply atherectomy or lithotripsy, and then assess again. This is my strategy, and prefer DEB for the first ISR and DS for recurrent ISR. For recurrent ISR, we can consider CABG. In conclusion, intravascular imaging can help to identify the mechanism of ISR, to select optimal treatment modality, and to optimize the acute result of the ISR PCI. DCB versus DES both are recommended as first-line treatment for ISR. Always, prevention is better than cure. Intravascular imaging-guided optimal stenting at initial PCI would minimize the ISR. Thank you for your attention.
Thank you. Wonderful lecture about the imaging-guided ISR PCI, right? Thank you very much. Yeah. Any question or comments from the panel? Yes, please.
Can I have a question?
Yes.
Yes.
Yeah.
Professor Akasaka, thank you. Yes, I think your recommendation to use DES after recurring restenosis after DEB, I think it's rational. But in case like a bifurcation lesion with multiple stents or with the two stenting strategy, I think it will be quite challenging. Like I think in the first case at the live demo, do you have any opinion on that situation? Recurring ISR, but in already maybe two-layered stent.
Yeah.
Yeah. Thank you.
Yeah. It's a wonderful question. I think yes. We do not know the final technique of the bifurcation lesion in this case. Therefore, and also the bifurcation two-stent technique, it makes a little bit complex, and too much stent is not so good. Therefore, we try to do the treatment without stenting, if possible, right? But it's depend on the case. Therefore, anyway, we try to check the response of the ballooning, right? And if we can avoid the stenting again, we try to use the DCB as Dr. Khan well done in this case, I think. Yeah. It is also our strategy. Yeah. Try to avoid the additional stent as possible as we can. That is our strategy. Yes. Any other comment from the panel?
Okay. So, Dr. Kwok. Okay.
Is there any limit for the use of DCB? Say one time, second time, third time. Is there any concern about toxicity, or especially paclitaxel, as there was some concern in PVD, in peripheral vascular disease, when you use too much paclitaxel balloon.
Yeah, that's also one of the problem. Yeah, at the moment there are some opinion about the prognosis using a paclitaxel ballooning, but not clear at the moment. Therefore, Also, the too much stent makes the patient prognosis worse, right? So,
yeah.
So it's midway, right?
So
we would like to have an
okay. So
final result, yes.
Peripheral artery disease, there is a meta-analysis showing
Yes.
the higher mortality, but
Right.
coronary artery disease and still there is no enough data, and for each patient, 2 times, maximum 3 times would be the maximum dose. I'm not sure, but I guess that would be not much problem. So I have one question to the Dr. Akasaka, and this session is a technical session, and many audience want to see after checking of the intravascular imaging like OCT or IBUS, and which finding would be optimal for pre-lesion preparation, like sometimes rotabulation, sometimes NC balloon, sometimes cutting balloon, and scoring balloon, sometimes intravascular resorption. Could you some technical tip and comment for the audience, and the beginner audience now is participate this session, which finding would be specific for region preparation tool that would be very helpful? Could you comment on that?
Right. We have to divide the instant restenosis and the native disease, right? In native case, I think the wire cross is most important. If we cross and if we can image, we can check the condition. And and if the calcium is not so big, we can check the calcium scoring system proposed by Dr. Fujino from CRF, right? If the score is less than 3, and we try to use the cutting balloon or modified balloon technique, and we try to check the condition, and finally we try to use a stent. And if we need the lithotripsy, might affect a little bit. If we cannot cross any imaging device or any treatment device, we have to use an atherectomy, right? And the orbital atherectomy or the rotational atherectomy. And then we try to image. And if the thickness of the calcium is less than 500 micron, we can make a crack using a cutting balloon or squaring balloon or non-compliant high pressure ballooning, right? And if we confirm the fracture of the calcium, we can put a stent. But if there are no fracture and still the calcium is very thick, lithotripsy shockwave may affect very well to make a calcium fracture. Anyway, confirming the calcium fracture is very important to before stenting. That is the very important, I think. Instantly stenosis, and we can check the histological condition by OCT very well, much better than the IBUS, as Dr. Khan said. Yes, and we often use OCT. Yes.
Okay. Any comment from panel? Any suggestion? Okay, Dr. Ng.
Yes, as for the instant restenosis, to our experience, because there has been no image guidance in previous days, so the mechanism of ISR are more or less something to do with the under expansion of the stent and the thick neointima growth. So my first line treatment will be almost always the cutting balloon angioplasty to prepare the lesion. Even some thin calcium arc can be break. If you make longitudinal cuts, and you can further dilate the vessel easily. So that's my recommendation.
Good. Okay. Any
questions?
Okay, great. Okay, Dr. Lippi. Okay.
Yes. In patient with ISR with the tight stenosis, and in the situation that we need a debulking, do you prefer to use a rotational atherectomy or orbital atherectomy that maybe can cut more tissues at the ISR? Any opinion on that or experience?
Yes.
Please,
the Park, please.
Yeah. So I think that is a very nice question, and now we are doing some random clinical trial. And Dr. Kang, can you explain our ROTA ISR trial? Is a concept?
Yes, in that undilatable ISR, we did some debulking or atherectomy. And so we are now conducting a randomized control trial, a small size 150 patient comparing routine rotational atherectomy in patients with neo-intimate hyperplasia versus just routine ballooning, like cutting or scoring. So routine debulking with the rotational atherectomy versus not. And now we are enrolled about 60% of the patients. Then that will show you the role of the atherectomy in the ISR PCI. And rotational versus orbital atherectomy, we should be better. And still, we do not have answers. So I will ask some more expert panelists about that.
Okay. Any comment?
I think yes. If the calcium is very concentric, right, the rotablator affects very well. But if the calcium is eccentric, and if we can use the wire bias, sometimes orbital atherectomy works very well, because orbital atherectomy acts as a skipping loop, right? Yeah. So during pullback or push in, you can decide the loop, right? Yeah. So it's depend on the condition, right?
So and the unfortunately, and the first case finally failed, and we will refer first case to the another option, bypass surgery and the LAD region and the peak to SUC and OM region. So I think we will have a very nice discussion time, and this session live case demonstration showed the wonderful scenario and imaging guided PCI for treatment recurrent ISR region. So I would like to ask Dr. Akasaka and the finish and the close and the summary on this session.
Okay, thank you very much, Dr. Park. Yeah, actually the case is very nice, instant stenosis, and by using OCT, Dr. Khan demonstrated the wonderful image to differentiate the mechanism of the stenosis, right? And we can identify the intimal hyperplasia with a fibrous neoatherosclerosis. Therefore, he selected the ballooning first, and then it is not enough. He selected the additional cutting balloon to dilate much bigger, and finally he did a kissing balloon and also final drug-coated balloon kissing, right? Yeah. I never seen the 30-second with kissing balloon in the left main bifurcation. You are so brave, I think. But the result is very acceptable and wonderful compared with an initial OCT. Yeah, lumen area is very well expanded. Yeah, they try to check the mechanism of restenosis. Is very important to treat the instant restenosis. So he did show us a very wonderful case to explain the image guide complex PCI, especially instant restenosis. And I would like to congratulate the wonderful results, Dr. Khan and his team, and also a wonderful discussion with all panelists. I really appreciate your attending this session. And also I would like to appreciate Dr. Park for giving me a chance to as a co-moderator. Thank you very much.
Thank you everyone, and please take care of yourself. I hope to everyone in person meeting in the next year. Thank you.
Thank you.
Thank you so much. Thank you.
Thank you.